the procedure itself is performed without direct visualization of the valve as this happens in surgical aortic valve replacement. And so it's really reliant on non-invasive imaging. And this is in order to help guide patient selection, device choice, as well as create a virtual roadmap of the truncal vasculature. Pre-procedural imaging has to be meticulous in order to minimize and avoid potential harm that can occur during the procedure. And so the advances in non-invasive imaging has really catapulted and supported the growth and maturation of the TAVR world. Previously, before the advent of CT, the annular sizing was based on 2D measurements, whether it was on transthoracic echocardiogram or transesophageal echocardiogram. And the problem with this was that back then there was an undersizing of the annulus. And this could be particularly due to the fact that as the progression of severe aortic stenosis occurs, the LVOT diameter takes an elliptical configuration, and this can lead to undersizing. And of course, with this approach, it is associated with a high rate of paravalvular leak, which, as we all know, is an important predictor of TAVR, post-TAVR mortality. So the gold standard now for TAVR imaging and planning really is computed tomography angiography. And compared to echocardiography, this is really an operator-independent imaging modality, and it does provide a full body assessment, which now includes 2D and 4D assessment. In the early TAVR era, the use of CT was for peripheral access assessment. But as with the progression and the advancement of CT angiography, it's really now used for various things, such as valve morphology. It helps assess whether or not an aortic valve is trileaflet. Is it bicuspid? Is there a raphe present? Where is it located? Obviously, with annular sizing. The importance of aortic valve calcification, not just on the valve itself, but as well as subvalvular in the LVOT. The extent, severity, and location of calcification is really important to know, because large protruding nodules can really contribute to the increased risk of annular rupture, particularly with balloon expandable TAVR valves. And so this is a specific thing that should be mentioned in all the CT reports. Coronary heights are important. The heights of the coronaries in relation to the aortic annulus is really important during the planning process, because particularly the left main ostium, because of the problem of obstruction. And with that, also not just coronary heights, but this is particularly may have the sinus dimensions may also contribute to obstruction. The coplanar fluoroscopic angles is something that's also now assessed on CT, is your deployment angle. And why is this important is because this can help reduce the need for repeat pre-deployment route angiography. So therefore, it helps save on contrast usage, radiation exposure, as well as your procedural time. And then lastly, of course, it comes down to access site. And it helps prevent possible vascular complications. Who is anatomically suitable for a transfemoral approach, because you do get the whole picture of the aorta iliofemoral vasculature. And if someone's not has an adequate vasculature for transfemoral approach, then you can also have assessment of other access points such as transcaval, subclavian, transaxillary, and carotid. In 2012, the first expert consensus statement of the use of CT for pre-TAVR planning was put out by the Society of Cardiovascular Computed Tomography. And in 2019, they updated their expert consensus document guidelines in terms of how to use CT imaging in the use of pre-TAVR planning. The pertinent components of that is provided on comprehensive report is everything that I've stated earlier, and which includes your valve morphology, your calcium distribution, obviously your aortic annular dimensions. You'll have it should provide the annular area sizing, your annular perimeter sizing. This is helpful whether you're using your balloon expandable valves, your self-expanding valves, the minimal and maximum diameters, because this will assist in whether or not if you have to post dilate your valves because of the amount of PVL that is present. Your coronary heights, obviously your ST junction size, and should report whether or not there's calcification on the ST junction, your sinus of Valsalva sizes, and obviously your coplanar projections. The comprehensive report of a CT scan in terms of pre-TAVR planning is also should also mention the pathologies of the aorta, the ascending aorta, the aortic arch, descending thoracic and abdominal aorta, and of course your iliofemoral vasculature. Because, as you know, especially if you come from a transfemoral approach, your delivery systems are coming up and over, and if there's a large amount of calcium, this can knock off and cause stroke. And so this can assist in those TAVR operators where with the use of cerebral protection devices, if it's not used in every single patient. And then obviously if it's found that a transfemoral approach is not feasible from the CT scan, then obviously the other evaluation of other access points can be stated. So after a CT is performed on a patient that's going for TAVR, post-processing is needed to get all of these numbers. And so there's different softwares out on the market and that can provide those pertinent numbers. And this is just a sample of one of those softwares. So not only do they provide the numbers, but they provide the pictures in order to show, coronary heights, obviously how your aortic valve looks, is it trileaflet, is how much calcium. Your aortic angle is really important because it tells, is it a horizontal heart? Can you come from transfemoral, or do you have to go alternative based on the aortic angle? Obviously your deployment angle, and then your annular sizing and your LVOT diameters, the sizes of your sinuses of Valsalva. The calcification, again, is really important to know, particularly if someone has a lot of calcium, especially in the LVOT area, because if you are choosing to we're choosing to go with a balloon expandable valve, this can really lead to to possible annular rupture, which is obviously a major complication. From your CT scan, you can get the 3D volume rendered images of the entire vasculature. It allows to see where those calcifications are located, how tortuous your vessels are, where the bifurcations are located, and how high up the inferior epigastric comes off in order to have to provide adequate access from a transfemoral approach, and then obviously the sizing. So overall, your final CTA report should mention everything that was stated previously in order to provide the TAVR operators with a comprehensive approach to how they're going to treat their patients with TAVR. So in summary, pre-procedural imaging, it is vital in the TAVR planning process. The gold standard imaging modality for TAVR planning is CT angiography. The comprehensive study the actual study itself should provide all of the assessments needed in order to proceed with the TAVR, which will include the sizing of the annulus and the approach route. And the anatomical reconstruction should occur with a post-processing system, and this is crucial to the overall planning. And lastly, all structural operators should always review the imaging on all of the TAVR patients. Thank you.
Great talk, Kim. I think we have Dr. Samir Kapadia in the audience now. As you know, Dr. Samir Kapadia knows he needs no introduction. He's the professor and chair of cardiovascular medicine at Cleveland Clinic. And he's been part of all the major trials since TAVR inception, including partner trials. And today he's going to talk about the TAVR, the past, the present, and the future. Dr. Kapadia, welcome. Can you please share your screen?
Hey, of course. Thank you very much, first of all, to organize this this wonderful seminar. Can you see my slides and hear me well?
Yes, we can see it.
Okay, wonderful. So the whole idea is that, first of all, I'm going to present in 10 minutes something for fun and try to understand where the field of TAVR is going. Thank you for the kind introduction. We started this journey 2003 Of course, Dr. Kribie had done the first case. So this is 2003. The typical patient in Cleveland Clinic used to be a 75-year-old guy with aortic stenosis, and this was the approach. So I went to see Dr. Cosgrove and said that, Dr. Cosgrove, we want to try this percutaneous valve. He said, you got to scrub with me for 100 TAVR cases before you say what kind of TAVR you want to do. This is how it is done. So I very strongly urge that if you are going to do TAVR, you got to go to the OR and see how people cannulate. This is the cross clamp, venous arterial cannula, how they opening the chest. And then these are the 6 steps. So you find the valve, you very nicely separate the valve leaflets, take it out, decalcify the annulus, measure the annulus, this is the measuring part, and then suture the valve carefully, and then make sure that there is no leak around the valve, and then close the aorta. And beautiful. The operation is most outstanding. It is not a complicated operation, very reproducible operation. From there, where we go now. So this is a slide that we show in all our TAVR, all our patients. We make this particular slide. So this is presented in our OR or in our hybrid room as our slide. It shows the history of the patient, the echo criteria, the labs, the cath, most important things that we want to do, and if there is an issue that we need to know about. And this is the team, so it is the very important thing that happened with TAVR was that now there is a team of people working together. So it's so much fun. Like today, I spent half of the day working with my surgical colleagues when the clip didn't go right and they wanted to operate. So the idea was that I was scrubbed with them. So this is very unique because in the past, this was never happening. So this is Dr. Svensson, Dr. Tuju, Navia, a lot of good people working together. This is our hybrid room, which is huge, but there are very few people. So this is a new style that although we have all the equipment, so in 5 minutes, we can go on pump, we can put the patient, whatever we need to do. But at the same time, there is not cluttering, there are not so many people, the resource utilization is less. And of course, nothing, no SWAN, no GA, no arterial line, no Foley catheter, none of that. And we are discharging the patient in the same day. Here, if you see, we also now access, so this is what is new. So we access the valve from the one groin. So we want from the valve access, go just below it and put another sheath just underneath, 5 French sheath, 8 French sheath, and a venous sheath. And we have a sentinel sheath from the wrist. We published that to say that if you just sentinel wire, sentinel device, and this is the sentinel trial, the classic trial that showed that there was a 62% reduction, 63% reduction in the event rate of stroke. I will come to that to say that this was not a stroke trial. So that's why we are doing a protected TAVR trial where we are getting to the endpoint of stroke and 3,000 patient enrollment trial. And thank you for the sites that are participating in the trial. So this is our style. So we are putting a straight flush catheter from the lower groin, pacemaker, and from here we will now do the TAVR. The sentinel device is placed, and TAVR, this is a balloon expandable valve, but we can do it in the self-expanding also, but we are placing the valve high. So again, to understand that we designed this thing that we put the line of the radio opaque line at the right part. See, this is how much the valve will shrink. So we put the line right there, and in RAO projection, not in the projection that commonly people use for the LAO with the ISO. This is a projection where we line up the valve in RAO caudal view, where all the valve is no longer having any, you take out the parallax and put the valve. This is the classic way. But if you put it in the classic way, you will feel that you are going to deploy the valve too high. But this valve is not too high, as you just saw that the valve is at 0. And what happens with that is that we have less pacemaker rate. We can discharge the patient. And at the end of the procedure, we just pace the right atrium. And if we can go to 120 beats, if we cannot make an assumption that the HV is good or not. But if we can pace at 120 beats the right atrium, then we know that HV can conduct at 120 beats, so we can discharge the patient in the balloon expandable valve. And we also check very carefully that what is the AR or not. And again, Echo is very important, but aortogram is crucial. So we do a good aortogram to make sure 20 cc's per second, 20 cc's 50-50 die, so it's 10 cc die. And then we also check hemodynamics. And hemodynamic measurement is very crucial. And there are several different things that you can use, different indices, and also the dicrotic notch. So if the dicrotic notch is above the 50%, there is not much AR. And then at the end of the procedure, to hold the pressure, patient goes home. What are the areas of interest? So there is a low flow, low AS, low gradient AS, leaflet thrombosis, bicuspid AS, and then the concept of lifeline management. Of course, we can elaborate on a lot of different things, but I just pick these 4 or 5 things for the future. So if you look at the patients who have what is the left ventricular, if you want to measure that this somebody has in the cath lab, what can you do to say if somebody has severe AS or not, if they're low gradient? So the very simple thing to do, and I thought it was very easy to do, is that if you measure simultaneous pressure, if we know that the carotid upstroke is delayed in the patients when they have aortic stenosis, what we say is that the peak systolic time, the peak pressure in the LV versus peak pressure in the aorta, if the delay is 66 milliseconds or more, then this is consistent with severe AS, because you will have enough calcium in the valve, and this will be a significant AS. So one simple pearl to take home. Leaflet thrombosis, again, a lot of data, a lot of different things to learn. But I think the most important thing is this is the most classic classification that we are going to use in the VARC-3. So 25%, 25 to 50, 50 to 75, or more than 75% of the leaflet that is affected by the thrombus formation. And it is a dynamic process. So this is the partner sub-study. And if you look at the partner sub-study, what you find is that the halt is present. Again, this is 7 days to 365 days, 7 to 30 days, and 31 to 365 days. So some of the halt resolves, some of the halt comes back. And the number of patients is variable, but is in that ballpark of patients. And here, if you see that their mean gradient is slightly higher, again, not statistically significant or maybe statistically significant, but it is very clear that if the halt goes more than 50%, then you start seeing some increase in the gradient. So again, how much is the halt is very crucial to know. For bicuspid aortic valve, a lot of efforts going on right now. I would say currently for the low risk bicuspid patients, we are not sending them to surgery. The TVT registry, this is the paper that we wrote from the TVT registry. Raj wrote this paper. And again, if you look at this, the implant success rate is very high. But if you look at the death rate is similar, but the stroke rate is somewhat higher in the bicuspid patients in the TVT registry. And this is self-reported stroke rate. So if you're going to use this data, I think using some kind of emboli protection is not unreasonable. And moderate to severe PVL is also significant in these patients. Balloon expandable versus self-expanding valve. Which valve is better? Again, moderate AR is slightly more. But if you look at the bicuspid valve versus a tricuspid valve, again, there was no difference in the overall time. This is the last concept that I'm going to end with. So to say that if you have a patient, are you going to put a valve? Are you going to be able to do valve in valve in the future? So either TAVR in TAVR, or SAVR. Very important. So the first thing to know is that you do the age. If the patient is very young and if the mechanical valve, forget it, surgery is the best. If the size of the valve is important, then if they're small annulus, maybe TAVR is better. If you're going to do TAVR, then how are you going to put a valve in valve? If you do the self-expanding valve, can you access the coronaries if you put a valve in valve, or the coronaries will have flow or not? So measure all these things upfront before putting the valve, so that when the patient presents later, you know exactly how to do it. There are a lot of different criteria to say that how in S3 valve you can put valve in valve, or how in Evolute you can put valve in valve. What should be the criteria? And a lot of literature. I cannot go in 15 minutes in that, but that's something to learn. Low risk trial, of course, everybody knows that the partner 3 low risk, this is 1 year data. Now 2 years data are published, or are very soon to be published. So you will see the 2-year data, and then the 3 years data are also going to be available probably in March next year. So far, so good. All the different types of bleeding, major AKI, everything is better for TAVR. So this is a good alternative for the patient. The durability is going to be, as time goes, we will know more about durability. I just want to share with you the Cleveland Clinic data. So this is 2018, 500 patients, no 0.2% mortality, 0.2 stroke, 0.8 more than 2 plus AVR, 5% pacemaker. Amazing data. And how can you get better? So 2019, we have 700 patients, no mortality, 0.3% stroke, 0.3% AR, and 1.2% pacemaker, 1.2% pacemaker. So, and 91% of the patients, only 9% of the patients with use general anesthesia are the people who are alternative access. So this is again, an amazing time. So I would say, yes, TAVR for all. This current day, we say that we consider TAVR for everybody. And if they are not good candidates for TAVR, coronaries are low, bicuspid valve, lot of calcium, then consider SAVR for these patients. So thank you for your attention. I know it was a little bit fast, but hope this starts some of the questions. Thank you.
Dr. Kapadia, making that bold statement, TAVR for all, and covering 2 decades of TAVR technology within 10 minutes, that is very impressive. Thanks for that.
Absolutely. Let me go ahead and as we're moving forward here, we'll hear from Dr. Sachin Goel, who is an interventional cardiologist at a Houston Methodist, and we'll be speaking to TAVR and HFrEF, reduced ejection fraction, indications and outcomes. So Dr. Goel, I think I've made you co-host, so you're welcome to share your, well, nope, now I have.
Thank you. Thank you for asking me to do this presentation. I'll share my slides. Can you see my slides and hear me well?
Yeah.
All right, great. So the topic is TAVR and HFrEF, indication and outcomes. Okay. So the outline of the talk is prevalence, pathophysiology, diagnosing severe AS in presence of HFrEF, management of severe AS and HFrEF, prognosis, possible earlier intervention. Prevalence, this is one slide showing the prevalence of HFrEF in aortic stenosis patients presenting for TAVR and SAVR. When we look at the patients with very low EF, less than 30%, the prevalence is about 5 to 10%. On the other hand, when we look at patients with EF between 30 and 50%, the prevalence ranges from about 25% to 35% when across the board. What is the pathophysiology? Well, HFrEF can be caused by the AS itself, by excessive afterload. The mechanism is left ventricular hypertrophy, pressure overload, followed by diastolic dysfunction, heart failure, followed by drop in ejection fraction and more heart failure. The probability of recovery in ejection fraction is high if AVR is performed in a timely manner, if the HFrEF is caused by AS. On the other hand, we do see patients who have HFrEF caused by ischemic cardiomyopathy, prior myocardial infarction, or other causes of cardiomyopathy. Again, improvement in this population is uncertain and sort of dependent on a case-to-case basis. This is a classic Braunwald slide showing the survival is poor after onset of heart failure without an intervention. The median, the 2-year mortality is 50% without an intervention. What about the diagnosis of severe AS in presence of HFrEF? This is the classic slide by Philip Pibero. Most of these patients, or a lot of these patients will present with low flow, low gradient aortic stenosis, meaning their valve area, calculated valve area by echo will be less than 1 centimeter square. However, the mean gradient also will be less than 40. Often the criteria for these patients is to do a dobutamine stress echocardiogram to look for a contractile reserve, which is defined by increase in stroke volume more than 20%. And then if they have a contractile reserve and the gradient goes up to more than 40, they are diagnosed to have true severe AS. On the other hand, if the valve area increases but the gradient doesn't, then that is considered pseudo-aortic stenosis and heart failure therapy is recommended. In those patients who do not have significant flow reserve, the AS can still be severe, and herein comes the role for multi-detect, the CT. So multimodality imaging is important, and based on existing literature, it has been shown that aortic valve calcium score of more than 2,000 in men and more than 1,200 in women gets them into the severe AS category, and they could be considered for an intervention. The other part of the equation is biomarkers such as BNP and NT-proBNP. And this is just one slide from Marianne Clevel's work from Mayo Clinic, looking at the prognostic importance of BNP in overall patients and also in asymptomatic patients. Higher the BNP, the worse the outcome. Again, the higher the BNP, the worse is the outcome, depending on AVR or medical therapy as well. So here, and this leads to the concept of checking BNP in these patients who may be asymptomatic, and there's an important role for biomarkers here. What about the management of severe AS and HFrEF? Of course, management is TAVR, SAVR, medical management. Dr. Kapadia would say TAVR for all. Of course, there are potential advantages for TAVR: less invasive, faster recovery, less healing, no ventilator dependency. TAVR does not require cardiopulmonary bypass. TAVR is associated with a higher effective orifice area, so possibly less incidence of patient prosthesis mismatch, and that might be more important in patients with HFrEF. What are the data? So I'll present a few slides on some of the key papers in this field. So some of the initial papers were from the partner trial. The partner trial, they looked at 900 patients, over 970 patients from the partner high-risk trial, of which 55%, about 530, were categorized to have low flow aortic stenosis, which was defined by stroke volume index of less than 35. About a quarter were low flow and low EF, meaning stroke volume index less than 35 and low EF less than 50. And about 15% were low flow, low gradient, and low mean gradient, less than 40. This analysis demonstrated that the 2-year mortality was higher in patients with low flow compared to those with normal flow. The upper panel here, the low flow versus the normal flow, which is the stroke volume index, 47% versus 34% 2-year mortality. There was no difference in mortality in the low flow with normal EF compared to low flow with normal EF. But the mortality, again, is almost 50% here when you look at mortality out to 2 years. Again, remember, these are high-risk patients. The third part is there was no difference in mortality in the low flow, low EF, low gradient versus those with low flow, low EF, normal gradient. But again, the mortality at 2 years was 50%. TAVR was associated with significant survival benefit compared to medical therapy alone. Here are the Kaplan-Meier curves, 76% versus 45%. In TAVR versus medically managed patients. And there was no no difference in survival between the TAVR and SAVR in these patients. So the conclusion was that low flow is common in severe AS and independently predicts mortality in this group of patients. Another analysis from the partner cohort A, almost 650 patients with EF of less than 50%, TAVR or SAVR. The mortality at 30 days and 1 year was similar for TAVR and SAVR, regardless of baseline EF and valve replacement technique, meaning whether they had TAVR or SAVR, the outcomes were similar. LVEF improved mostly by 30 days after both TAVR and SAVR. And these are the mean improvements in the ejection fraction in both groups, in the TAVR and SAVR groups. So both groups benefited with an intervention. Failure to improve EF at 30 days was associated with higher MACE, but only after TAVR. And then higher baseline EF, low mean gradient, and prior pacemaker independently associated with reduced odds of LVEF recovery. These were the main findings from this study that was published in Circ Cardiovascular Interventions. What about the real world data from STS-TVT? This was published by Susan Barron and Jack, more than 11,000 patients from the STS-TVT registry, about 800 with EF less than 30%, about 2,900 with EF 30 to 50%, and the remainder with EF more than 50%. So on the left panel, you can see the mortality and recurrent heart failure. Of course, not a surprise, patients with lower EF had a higher mortality and a higher incidence of recurrent heart failure out to 1 year. They stratified also patients based on their gradient, the mean gradient of less than 40 versus more than 40. Again, higher mortality and heart failure in those with lower mean gradient compared to those with high mean gradient. This is another way of looking at the data. Mortality on the top and heart failure on the bottom, stratified by EF and mean gradient. When they did some adjusted analyses between the EF and the gradients after adjusting for baseline characteristics, however, the EF did not remain an independent predictor anymore. However, the mean gradient of less than 40 remained an independent predictor of poor outcome at 1 year, meaning mortality and heart failure. Lastly, TOPAS TAVI was the most recent registry. It was a multi-center registry of 293 patients with EF of less than 40%, of whom 128 patients had very low EF, defined as less than 30%, and the remainder with EF of 30 to 40%. 30-day mortality was 4.1% in this cohort. However, there was no difference between very low EF versus low EF, 4.7 versus 3.6. Late mortality at 2 years, almost 50%, similar to the partner data, but again, no difference between the very low EF versus low EF. There were greater increases in the LVEF in the very low group, and dobutamine echo-defined contractile reserve had no effect on clinical outcomes or change in ejection fraction in this registry. Similar to the partner, the balloon expandable valve, in the self-expanding valve cohort, it was shown that about 2/3 of patients experienced recovery of ejection fraction early in the course of their follow-up after TAVR. However, patients also continue to have recovery after 30 days. At 1 year, when you looked at patients who had LV recovery versus no recovery, there was no statistically significant difference in the mortality, although numerically the mortality was almost twice in those who had no LV recovery compared to those who had LV recovery. Absence of prior MI and baseline gradient more than 40 were predictors of early EF recovery in this patients undergoing self-expanding TAVR. Here is an example of a patient that I just did a few weeks ago. This was the pre-TAVR echocardiogram. This is a classic example of HFrEF. Ejection fraction is around 25%. And immediately after TAVR, in fact, post-procedure, the patient's ejection fraction improved to near normal. And we see this commonly. Lastly, what about earlier intervention? So right now there's a unload TAVR trial going on, which is evaluating the role of TAVR in patients with HFrEF, ejection fraction less than 50%, who are symptomatic, but with moderate aortic stenosis, randomized between TAVR and heart failure therapy medical management versus medical management alone. And this is an ongoing trial which will help us understand the role for earlier intervention in these patients with HFrEF with moderate aortic stenosis to see if unloading their ventricle will improve outcomes. So in conclusion, HFrEF is frequent in patients referred for TAVR and constitutes an adverse prognostic factor. Diagnosis may require multimodality imaging, including dobutamine echo or CT or both. Survival is improved with TAVR compared to med treatment alone and similar with SAVR and TAVR. Low flow, low gradient, low EF, failure to improve EF are predictors of mortality. However, these by themselves should not be a reason not to offer therapy. And there may be potential role for earlier intervention in asymptomatic patients and also those with moderate AS, which is currently being studied in randomized clinical trials. Thank you very much.
Thanks, Dr. Goel. That was wonderful. And now I have the honor of introducing Dr. Kendra Grubb. She is an associate professor at Emory University, and she is also the director of the structural surgical program there. And we're so happy to have her here and also representing women in cardiology, especially in surgery. So thank you, Kendra.
Let's see here. All right. Well, I have the opportunity here to talk a little bit about TAVR access and options and complications. As mentioned, I am the surgical director of the Structural Heart and Valve Center at Emory University, and thank you for this opportunity. So here are my disclosures. So the first TAVR, as mentioned earlier by my colleagues, was done in 2002. And at that time, this was a percutaneous technique. However, as you can see from the pictures, Dr. Cribier decided to go transseptal antegrade across the valve. And this is one way to put in a TAVR. However, it never really caught on in any of the major trials. And so we're going to talk mostly about where we are today. So the early options for TAVR, transfemoral was always the primary approach, with the alternative access being transapical and transsubclavian. And then direct aortic became another option. And part of the reason why we needed some alternative access was that the early devices required extremely large bore sheaths, Oftentimes this required a femoral cut down. As you can see, the early Sapien devices required a 22 or 24 French sheath, and then down to 16 or 20 French sheath once XT came into the picture. And the early CoreValve Classic, 18 French outer diameter. So these required very large access in patients who were often elderly and frail with heavily calcified vessels. And what we found was that up to 30% of patients in the early trials were not candidates for transfemoral access. And here are these large sheaths, as seen in this picture. You could have this awful complication, which was an iliac on a stick. And unfortunately, we saw this more frequently than we would like to. And so we were really critical of that preoperative imaging that was mentioned earlier and making sure that we didn't have vascular injuries. In fact, 7% vascular injury rate in the higher transfemoral trials. So we really needed to be conscious of who was not a candidate. And transfemoral access is always going to be limited by vessel size, tortuosity, angulation, and any type of prior surgery or stent. Now, I will say sometimes you are able to do TAVR through a TAVR with stents in the iliacs, but oftentimes you have to be very critical of what you're trying to accomplish. With the smaller devices today, this is more easily achieved. Here you can see heavily calcified areas in the iliofemoral system. Now, is this a candidate for shockwave? Well, maybe, but how about some alternative access choices? Again, before we get to the alternative access, just a reminder of where we've come from. So 22 to 24 French sheath, down to 14 to 16 French sheath in the partner trial. And for the Evolut valves, down to an 18 French OD, which now can accommodate down to 5mm vessels. And this is true for the Pro Plus as well. So really, we've come a long way since those early devices. So transfemoral, it was initially performed by a cut down, now routinely totally percutaneous. The operator stands in a very typical position with appropriate radiation protection. Vascular complication rates initially limited the technique, and now 95% of patients are candidates for transfemoral access. So here you see the progression, and transfemoral really being the predominant access of choice at this point. So we'll talk about these different access approaches: transsubclavian, transseptal, transaortic, transcaval, transcarotid, and transapical. We'll go through each of these briefly. And some of these are just as a historical perspective in my mind, this being one of them. A transapical approach was really the first alternative access option for the partner trial. As you can see here, it requires a maximally invasive mini thoracotomy. It's the only antegrade approach that was really in the trials. It makes it very easy to cross the valves, but it requires general anesthesia. It's poorly tolerated by elderly, frail patients, especially those with COPD. The patients often have to go to the ICU for recovery, and there were increased complication rates, a mortality rate of 5% at 30 days in the high-risk partner study and 14.2% for nonagenarians. So we really have to use this as a historic perspective and the access of last resort. Similarly, transaortic is also a maximally invasive, requires general anesthesia, partial sternotomy or mini thoracotomy, and the patient requires ICU postoperatively, higher rates of bleeding and transfusion, with again, high mortality, 6.1% at 30 days in the large registries, but unfortunately also with higher stroke rates than transfemoral. The benefit is easy positioning. This makes for a direct access to the aortic valve. So there is a role for it, but it should be reserved for those patients who really have no other options. Getting to the transsubclavian and transaxillary approaches, this was one of the first alternative access options in the self-expandable valve trials. This avoids violating the thoracic cavity and is much better tolerated by the patient. It initially required general anesthesia and a cut down, but now, as depicted in this lower picture, you can actually do this totally percutaneously with closure of the device with the same perclosed devices that we use for percutaneous transfemoral access. The mortality is similar to transfemoral, with no difference in outcomes at 30 days in the CoreValve pivotal trial. However, it has been associated with higher stroke rates, up to 6% with the Sapien 3 device. And it's also ergonomically challenging as you're in a very odd position standing at the patient's shoulder. and there's increased radiation to the operator. As you can see here, as I'm attempting to close the arteriotomy, my hand is getting blasted by radiation. As you can imagine, so is my head. And so, yes, this is a feasible way to do this, but not ergonomically the same as a transfemoral. The shielding is not set up the same in these in the operating room. So yes, it can be used, but maybe there are other approaches. And this is, of course, questionably suitable for patients with a prior CABG with a patent Lima to LAD. Moving on to transcarotid, described in 2010, but not included in any of the trials, requires a surgical exposure and experience on the operator's standpoint, similar morbidity and mortality to transfemoral, with some reports of increased rates of stroke up to 4%. It can be done under local anesthesia with conscious sedation and next day discharge, but really this is a procedure that the surgeon needs to be comfortable with in order to use this as your alternative access of choice. Transcaval, it happens to be that transcaval is our alternative access of choice at Emory. So I'm a little bit biased, but I'll explain to you why. It was initially reported in 2004. It's the only alternative access with a prospective study data, 99% successful access, 98% successful closure, and 30-day survival of 92% in the study that was led by Dr. Greenbaum. This can be done totally percutaneously. It can be done under conscious sedation, and the patients can be fast-tracked on the same pathways as transfemoral TAVR. In addition, the ergonomics and radiation exposure are also similar to transfemoral TAVR. The early results with showed increased need for blood transfusion, and now 7% reported VARC2 bleeding. So the optimal alternative access, if you can't use transfemoral, the results should be similar to transfemoral for death, stroke, major bleeding, and vascular complication. Totally percutaneous techniques should be used, avoiding intrathoracic approaches. A minimalist pathway with conscious sedation, early ambulation, and next day discharge should take priority. And it should be ergonomically similar to transfemoral TAVR with minimal radiation to the operator. And so in summary, we have many access options. And here's a chart of the alternative access options that my partner, Dr. Adam Greenbaum, presented at London Valves a year ago. And as you can see, none of them are perfect. There are trade-offs. And I think the most important thing is that you transfemoral first. It should be at least 95% of your patients. And when you decide to do an alternative access, pick one that you and your site are most familiar with, most comfortable with, and become a master at that one. You don't have to be able to do all of these, but you have to do alternative access well, at least by one of these techniques. And with that, I thank you for your time today.
Thank you, Dr. Grubb. Next on is Dr. Atianzar from University Hospitals, Cleveland, Ohio. He's a director of valve and structural heart disease. His topic will be available TAVR devices. Which one is better? Dr. Atianzar?
Thanks very much for the opportunity of this talk. Please let me know. Can you see my slides?
It came on, then it disappeared.
Can you see my slides?
No, we can't see it yet.
Yeah, maybe a bandwidth issue. Look like it's
can you see my slides?
Not yet.
Let me try to. I
there
can
we go.
see them as if I was. Let me try one more time here. Sharing 1 second. Can you see it?
Yes, we can see the slides. We are seeing slide number 38.
Can you see my slides?
Yeah, we are seeing your first
Yes.
slide. Yes.
Excellent. All right, so thanks for the opportunity. Thank you for the opportunity here.
Dr. Atianzar,
Oh no, I think that, yeah. Looks like your
slides dropped, Dr. Atazani. We cannot see it. Now we can see it.
may have an unstable internet access there. Let's see, he's mute. There we go.
Can you see me?
Yep, now we can see and hear you.
Okay, thank you. So I'm sorry, I apologize for the inconvenience. So we're going to discuss today amongst the available TAVR devices that we have, which one is the best one. So this is my disclosure. So there are several different devices obviously available outside the United States, and we narrowed down the options in the United States to 2 devices. Self-expandable supraannular platform of CoreValve, and more recently Evolut Pro and Pro Plus, and the balloon expandable valve of Sapien, and today Sapien Ultra. So I was trying to think of what would be the ideal TAVR device. So the ideal TAVR device is the one that has an optimized delivery system, the one that minimizes or abolishes PVL, as well as optimizing hemodynamics with low permanent pacemaker implantation rates. We want also, of course, a device that is safe, that enables us to do either TAVR in TAVR and TAVR in SAVR, that enables us to treat challenging situations such as bicuspid valves, and obviously, as was discussed in prior talks today, that enables us to preserve coronary access and enables us to plan the life of our patients long-term. Durability, very important here. So let's discuss about the optimized delivery system. So as was discussed in terms of access, right? When you compare the devices that they have available today with Evolut Pro Plus, it would enable us to treat vessels that are bigger or equal than 5 millimeters versus a little bit bigger for Sapien 3, right? Or Sapien Ultra. That would enable us to treat approximately 17% more patients because a lot of people, as we know, have smaller vasculature. So there is a little bit of a slight advantage for Evolut that enables us to treat patients with smaller vasculatures compared with the current technology of Sapien. On the other hand, the deliverability, the ability to flex the Sapien catheter versus the spines of the Evolut technology may also enable us, the ability to flex the catheter may enable us to deliver the valve in more challenging anatomies. So I would say that there is a potential advantage for the flexible catheter of Sapien in this scenario in very challenging anatomies. In terms of the paravalvular leak or reducing or abolishing paravalvular leak, right? This is a nice slide because we can pay attention to the evolution of this technology, right? Starting with CoreValve on the left, passing by Evolut R, and more recently to Evolut Pro, right? We can see that there is a progressive reduction in paravalvular, and we have really great results with the current technology of Evolut Pro and Evolut Pro Plus with 0% moderate and severe PVL at 30 days. And when we look at Sapien, similarly, compared with Sapien XT and now Sapien 3, and now the recent technology, the recent iteration with Sapien 3 Ultra, there is also a reduction in paravalvular leak, which the numbers, if you pay attention to the numbers, they're very similar between Sapien Ultra and Evolut Pro Plus. So I think there we have today very similar rates of paravalvular leak between the two technologies that we have available. Optimize hemodynamics, extremely important topic here. So this is the only study that really randomized these two technologies. It's important to say that this study was conducted years ago, and it did not include the current iteration of these two technologies, and also, of course, the knowledge of the operators that there have been several changes in in deployment techniques that enabled us to optimize both devices in terms of their deployment. But it's interesting to pay attention, and also, of course, we have to understand that the sample size of this study was not large, but it's important to look into the data. Out of 5 years, there was a better hemodynamic performance of Evolut compared with Sapien in terms of gradients and in terms of EOAs. Although this is statistically significant, we have to understand if this is going to be clinically meaningful, right? So that's an important question that we have to ask ourselves, but it's important to pay attention to this data. And when we look at the rates of structural valve deterioration, there were higher rates with the balloon expandable valve compared with self-expandable valve. Again, small number of patients, but at least is the only randomized data that we have comparing these two technologies. There was, although not in terms of paravalvular leak compared with core valve, but however, importantly to emphasize the fact that these are not the current iterations of the valves, and as a higher rate of valve thrombosis with the balloon expandable valve. It's also important for us to pay attention when we compare these studies. This is the Notion study comparing surgical aortic valve replacement versus TAVR over time, showing that there was higher actually rates of structural valve deterioration with surgical valves. And looks like that the self-expandable platform did extremely well over the 6 years follow-up. And when you look at it by Dan O'Hare, showing that also Evolut did a pretty good job over time compared with surgical valves in terms of durability. Looking into the PARTNER 2 trial and the 5-year follow-up data, showing that although Sapien 3 did a quite good job compared with surgical valves here in yellow, but there is an interesting data that we have to pay attention to, which is from Sapien XT, although it's not the current technology anymore. But there was a higher rate of bioprosthesis valve failure over time compared with surgical valves. So we have to pay attention to this data, and I think that I don't think we have to have any robust conclusions from this, but at least it's something that we have to pay attention to. Importantly, also the avoidance of patient prosthesis mismatch. This is data from Howard Herman, large number of patients from the TVT registry. I want you to pay attention to the fact that still, even with TAVR, there's a good amount of patients that end up, leaving the room with patient prosthesis mismatch. And these two, the utilization of a valve size of less than 23 and valve involved were the highest predictors, the most significant predictors of patient prosthesis mismatch. And looking into this data from Beckingham, when we pay attention to the quintiles that she divided these patients here, looking at the possibility of patient prosthesis mismatch, more often happening Evolut. So looking at the DVI, the DVIs of Evolut were consistently better compared with the DVIs of Sapien. And why this is important? Well, because this is data that was recently presented by Nicholas Lamigian, showing that the DVI, which is less than 0.5, might have an impact in all-cause mortality down the road, either with SAVR or with TAVR. Low permanent pacemaker rates, as we can see here, the Sapien family progressively reducing pacemaker rates, as well as the Evolut family, although you can see that the numbers for core valve are higher than the Sapien numbers. This is the number of the Evolut low risk trial, which was quite high, 17.4%. This is the TVT red. This is the data we have here. So we have 4.1% pacemaker rates with Evolut. There are a lot of different discussions in terms of technique of shallow implantation versus cusp overlap. So there are ways of reducing pacemaker rates with Evolut, and then of course there is the data, and Kendra is on the line here. She's one of the principal investigators of the Optimize Pro, and I'm sure that these numbers are going to come down dramatically. And indeed, when you look at the results from Sapien, the results were definitely have been consistently better with 6.5% of pacemaker rates in the low risk SAPIEN trial. And this graph illustrates everything that we discussed, looking at when you compare Evolut platform versus the SAPIEN platform, consistently a better performance of the SAPIEN platform in terms of permanent pacemaker implantation. Now, safety is, of course, a very important topic here. The ability to recapture Evolut, I think, delivers safety to the mechanism, mostly for smaller centers, folks who do not implant many valves. I think it's a very important feature. We just published this data on jack interventions showing the safety of the recapture mechanism of Evolut, and obviously the fact that the annular rupture that we'll discuss in the CT talk also very important. Obviously, the valve does not rupture the annulus. What does rupture the annulus is a potential pre or post dilatation. But this is a very not frequent complication, but importantly, of course, higher with the balloon expandable valves. Ability of performing valve-in-valve procedures, either TAVR in TAVR or TAVR in SAVR. This is the data that we presented recently on TVT, and it's under review right now. Just wanted to show you the valve hemodynamics. So this is data from the TVT registry, looking at the valve hemodynamics of Evolut. I want you to pay attention to the gradients of valve-in-valve of Evolut. We can see that low teen gradient. So that's a very robust performance of this device, considering it's a valve-in-valve procedure, right? And obviously, the rates of paravalvular leak are very low, and same for permanent pacemaker rates. This is Evolut Pro 2.6% pacemaker rate with Evolut Pro in valve-in-valve. This is data from the SAPIEN family. If you compare the difference in gradients for valve-in-valve here, 17 versus 11 in the Evolut family, there is definitely a difference there. Again, it is important to then understand whether those differences are going to translate into worse clinical outcomes. And apparently, according to this data, when you have mean gradients above 20 millimeters of mercury, there is an impact in long-term mortality after valve-in-valve. So there is an indication that high. And when you look at this graph on the right side of the screen, you can observe that most of the times, right, when you deal with smaller surgical valves, obviously this happens more often, and even more so when you deal with SAPIEN valves inside small surgical valves, 41% rates of post-procedural gradients greater than 20, and that of course catches up when you deal with larger surgical valves. And also the rates of reintervention were higher with SAPIEN in valve-in-valve. This was just presented by Danny DeVere. Bicuspid valves, data that was presented previously here, just showing that this is the matched cohort of the TVT registry, showing good performance of the SAPIEN valve in terms of stroke and all-cause mortality over time. This is the data of Evolut. Also, this is a registry. This is not randomized data, but it's saying that there's promising low rates of aortic regurgitation, improvement in New York Heart Association, and low rates of paravalvular leak with the Evolut technology. As you can see, almost 80% of 75% of non-to-trace paravalvular leak. So that's pretty remarkable considering the more adverse anatomy of bicuspid valves. And just finally, I'd like to talk about the preservation of coronary access, which is definitely feasible with the Evolut family, and Gilbert Tang demonstrated this on this paper. The ability of doing commissure alignment, which you cannot do with the balloon expandable valves, is basically flipping a coin, would enable easier coronary access down the road. Of course, we also understand that coronary access matters also the baseline anatomy of the patient. That plays a major role in the ability of having access to the coronaries, not only after the first TAVR, but also post-TAVR and TAVR. And we know that there will be some patients that we're going to have a hard time to have coronary access down the road, either with SAPIEN or with Evolut in future when these patients potentially get a TAVR in TAVR down the road. So we need new technologies to be able to mitigate this problem. And finally, this is, I think, just wanted to share with you, this is the data that we presented on TCT. This is the largest experience of TAVR in TAVR that we have under review also, just showing that the performance of the Evolut platform was great in this series of more than 200 patients with low gradients, low teen gradients and very low rates of paravalvular leak. So just to conclude here, the current FDA-approved transcatheter heart valve demonstrated significant performance improvement compared with their prior iterations. The only direct randomized comparison between the available devices utilized prior iterations and did not incorporate the current knowledge of optimal implantation technique. Therefore, the results have to be interpreted considering these factors. There's a potential hemodynamic benefit of Evolut compared with SAPIEN, mostly in TAV and SAV, and also in a smaller annuli. The upcoming randomized SMART trial is going to shed some light on the latter. And finally, the rates of permanent pacemakers have been overall higher compared with SAPIEN. However, optimized implantation technique for the former dramatically reduces this adverse event. Long-term durability data suggests a plus data is warranted to define our understanding in this subject. And finally, long-term management enabling future coronary access in TAV and TAF might be challenging for both devices. And the attention, and my apologies for my poor internet connection.
Thank you, Dr. Atianzar. Next, we have an upcoming leader and rising star, Dr. Rahul Sharma from Stanford University. Can you guys hear me?
Thank you, Sohail, and thank you to you, Martha and Viet, for the kind invitation. Can you see my screen?
Yep. Yes, we can see it.
Okay. Terrific. These are my disclosures. So I'm going to be talking about bicuspid valves and aortic regurgitation today, and try as best as I can to get through that in 8 to 10 minutes as we have that much time. So I'll start with bicuspid valve, and I'll probably spend most of my time talking about bicuspids and spend a little less time talking about aortic regurgitation. But we're all familiar with the Sievers classification of the type of bicuspid valve, and that's really important in ascertaining what morphology of bicuspid valve we're dealing with, because as you'll see shortly, that has an impact on clinical data and clinical decision-making, and may in fact sort of pave the way about how we decide whether or not to use TAVR to treat bicuspid patients, and if so, what the most appropriate strategy and device is. So the majority of patients fit into the type 1 classification, where there's one RAFI with fusion of both the cusps, and the predominant pathology of that is a left-right fusion. So in my practice, this is sort of my approach. CT is obviously the mainstay of screening these patients, and carefully looking at the size and morphology of the valves, looking at the degree of oversizing, both the volume and distribution of the calcium, the eccentricity that often accompanies bicuspid valves, and what the minimum and maximum dimensions of the aorta are, and then the presence of any coexisting aortopathy, as we often find in these bicuspid valves, particularly those true congenital bicuspids in the type 0s. Determining the appropriate coplanar two-cusp view is even more important and sometimes somewhat more challenging in these bicuspid patients. And then whether or not there's a need for coronary protection that sometimes arises from those asymmetric leaflet lengths that you often see in bicuspid valves. And then a question about the need for a balloon aortic valvuloplasty. So at least in my practice, while I don't do a lot of pre-dilatation in tricuspid valves, in bicuspid valves, I almost always pre-dilate. I usually start with a nominal sized valve, and I aim to land these valves even higher than usual with a 95, 5, or even higher deployment. I generally prefer the S3 platform over the core valve or Evolut platform. And while we do all these cases under conscious sedation, there's careful TTE assessment or look at the PVL to determine whether we need to post-dilate. And that's done with a degree of caution, usually determined by the degree of calcification. So if we look at the data that we have so far underpinning this, and some of this was presented earlier, so Raj Makar, former colleague at CEDARS, really started this off with a large match study using the TVT registry. The most important sort of procedural outcomes to take away from this was that the conversion to open surgery was slightly higher in the bicuspid, still under 1%. There was a significant difference there. And annular rupture, there were no cases of annular rupture in tricuspid aortic stenosis, but a very low rate although I think you would argue that any rate, particularly as we move into a younger, lower risk population, is not acceptable, was a difference between the two groups. The need for a second valve is also higher in the bicuspid aortic stenosis group. Now remember, the period of this study was over quite a few years with different devices used. And so there was obviously a learning curve with experience as well. Strokes between the two groups were different, and this has been one of the criticisms of TAVR in the bicuspid arena, is the increased stroke risk that arises from bicuspid valves compared to tricuspid, and a lot of that is attributed to the greater degree of calcification or the fused RAFI when you're passing wires, catheters, and indeed valves across the aortic annulus. There's also a slightly higher incidence of pacemakers in the bicuspid cohort as well. When you look at 1-year mortality, which was matched in this group, there was no real difference or no significant difference between bicuspid and tricuspid patients out to 12 months. Importantly, when you looked at stroke and matched the patients in the cohorts, remembering that a lot of the patients in the bicuspid tend to be younger, therefore they have fewer comorbidities, therefore they have a lower STS risk score. Once these patients were matched, that difference really was non-significant. I think it's also important to remember, though, that the caveat to this is that bicuspid patients tend to be selected in that the patients that we generally take to TAVR are those that are lower risk, whereas the high risk patients may go to surgery. So there's certainly a selection bias inherent simply in the patients who go to TAVR who have bicuspid valves. When you looked at mortality or stroke as an outcome, once again, the matched cohort demonstrated no significant difference between the two groups. We looked at paravalvular leak, which is again one of the other criticisms aside from stroke of these patients. Often they have a lot of heterogeneous calcium distribution, and therefore, regardless of the valve type used, there's a concern for perivalvular leak in these patients. But pleasingly, you see there that the vast majority of patients had no significant leak, and very small proportions of patients having significant leak after their procedures out to 1 year. When we look at the data from circulation published by Halim and colleagues this year, they were a much more updated registry from the TVT and STS group. And again, they showed a difference in mortality between bicuspid and tricuspid, but no significant difference in terms of stroke. The difference between this study and the prior study from Dr. Makar's group was that these were not a matched cohort. There was no CT core lab adjudication of the morphology of the valve. And in fact, in about 12% of patients, there was no CT data available to ascertain whether the morphology of the valve was truly bicuspid or tricuspid. The other important caveat is that the Evolut Pro device, you'll recall, was only approved in 2017. And so this data going back quite a few years prior to that doesn't necessarily include the latest generation devices. And so this was their conclusion. With that current generation transcatheter devices, the incidence of device success was only slightly lower for bicuspid patients compared to tricuspid patients, with residual 2 or greater aortic insufficiency being present in under 3% of patients. And it was slightly higher in the bicuspid group. There was no difference in the adjusted 1-year hazard of stroke in patients bicuspid versus tricuspid in this series, and the 1-year hazard of mortality was in fact slightly lower in the bicuspid group. John Forrest and his group published earlier this year in JACC Intervention, focusing on the Evolut R and the Evolut Pro data. So looking at a much more contemporary device and focusing on the Medtronic platforms. They too matched their cohorts and showed there that there was no significant difference in all-cause mortality between the bicuspid and the tricuspid groups. Importantly, in terms of perivalvular leak, the vast majority of patients had no or mild perivalvular leak, with a very small proportion of patients having significant leak. In addition, they showed no significant difference in terms of stroke between the two groups. Now, one of the questions raised was, how does the anatomical morphology of bicuspid valves alter clinical outcomes? And this led to Dr. Makar's group and Dr. Yoon developing the bicuspid registry and then analyzing this large multi-center international registry based on the nature of the bicuspid valve. And they divided these data based on the presence of RAFA, whether they were calcified or not. And they also quantified the volume of calcification. And what's something that was rare in some of the data we're seeing presented, also looked at the presence of aortopathy, which was not available in some of the TVT and STS registries. They also divided the groups up into device based on early or late generation or current generation. So this is what the group looked like. You can see across the top, the differentiation by the presence of RAFI in that first column, non-calcified RAFI in the middle column, and then calcified RAFI in the column on the right, and then separating those into having mild leaflet calcification or excess leaflet calcification. And you can see there that the combination of excess leaflet calcification and calcified RAFI, just to the naked eye, looks like the worst. And you'll see shortly that also translated to more adverse clinical outcomes. And so you can see here there's a clear separation and divergence when you have calcified RAFI in terms of all-cause death compared to non-calcified or no RAFI. In fact, no significant difference between having a non-calcified RAFI or no RAFI at all. When you look at the presence of leaflet calcification, as one would expect, excess leaflet calcification had a very early and pronounced divergence compared to mild leaflet calcification in terms of all-cause death. When we looked at all-cause mortality and aortopathy, again, a clear divergence with aortopathy associated with an increased risk of all-cause mortality. Now, again, this study was over quite a few years. It's a large registry. And so what they teased out was what is the more contemporary and therefore relevant information. So looking at low-risk patients with newer generation devices. And what we found is that group where the valve looked the worst, that is that had calcified RAFI plus excess lethal calcification, they did the worst with a significantly higher rate of all-cause mortality based on that bicuspid phenotype. When you looked at other outcomes, PVL, aortic root injury, major vascular complications, and 30-day mortality, once again, the highest risk was in that group who had a calcified RAFI and additional excess lethal calcification. And interestingly, very little difference between a group that had either calcified RAFI or excess lethal calcification and those that had none, meaning the combination of the risk factors was really the significant issue. So when they compared this between the two types of devices, they looked at the balloon expandable devices, and you can see there the rates of adverse events based on those outcomes. And then just keep that in your mind's eye as we look to the self-expanding devices, which again showed that same trend with an excess of adverse events if you had a calcified RAFI plus excess lethal calcification, but a numerically higher percentage across all of those adverse outcomes. Now, important to remember, this is registry data that's just not compared head to head, and it's certainly not randomized. So it's hard to draw too many conclusions from that, but just an interesting observation. So in summary, on the bicuspid valves, the bicuspid group represents a very challenging subset of patients. We need to have a careful assessment of the CT to identify the high-risk characteristics, such as the presence of RAFI and excess calcification. That will help guide appropriate valve type and size selection and therefore procedural planning in order to minimize complications and unsatisfactory clinical outcomes. Where are we going in the future? I think we still need to understand the impact of aortopathy in the TAVR population. We don't have a clear handle on that based on the limited data we have. We're still learning what the ideal valve type is for bicuspid anatomy. There is divergent data on which is the ideal valve type, and I'll talk a little bit about valve types for AI, but we don't really have a dedicated valve type to suit bicuspid valves. The role of cerebral embolic protection, we saw there's again been some disparate data on the role of cerebral embolic protection in the tricuspid space. Whether or not this translates to the bicuspid arena remains to be seen. Often those patients are left off some of those other trials as an exclusion. Given the adverse events associated with excess calcium, one may imagine that cerebral protection may have a greater role in these patients, but that remains to be demonstrated clearly. And finally, one of the biggest dilemmas or arguments or debates is there a need for a randomized controlled trial in low-risk patients? A lot of people will say absolutely. What should the comparator arm be? Should it be surgery, given that's the gold standard? The problem is it's unlikely that we'll find an industry partner who's going to be willing to sponsor a trial, given that TAVR is already approved in the low-risk cohort, regardless of valve phenotype. In the last couple of minutes, in the interest of time, I'll speak briefly about aortic regurgitation and the role of TAVR. There are some limitations of TAVR and aortic regurgitation compared to aortic stenosis. The first is device sizing and the difficulty in terms of trying to determine the appropriate amount of oversizing while still being safe for the procedure. There is a risk of embolization and migration of the device because of the lack of calcium in these valves, the presence of residual aortic regurgitation, and then of course conduction disturbances that arise from these, mostly as a result of deploying these valves deeper in order to try and minimize embolization or migration. There's clearly been a clinical difference in terms of improvement with outcomes when we look at old versus new generation devices. This is a really nice summary from Gilbert Tang that shows you, if you just bring your eyes here, the old generation device versus the new generation devices in terms of the difference in clinical outcomes, improvements, both in terms of the need for a second valve, which was very high in our early experience using the older valves, the presence and prevalence of moderate to severe AI, the need for a pacemaker, and then the 30-day all-cause mortality. Across the board in most of these studies, a clear improvement in clinical outcomes with the newer generation devices with the improvement in technology. There are two dedicated devices for TAVR. The first is JenaValve, which currently in the United States is part of a feasibility study for the transfemoral approach. The first approach was transapical and there was mixed outcomes. The way this valve is deployed are these anchors find the nidus of the coronary cusps. Once they are firmly at the nadir of those cusps, the valve is deployed in a two-stage approach where the functioning valve is deployed at an intraannular level, and then the second part of the valve is released, rendering the valve in place, and it's kind of anchored there on the cusps. As I said, we're an early feasibility study with a transfemoral approach in the United States. The second dedicated valve is the J valve from Dr. J in China. Similar principle, where these groups are designed to find the valve is deployed in a similar fashion. There have been some mixed results in the United States, and currently the focus of the company is gone back to China, where they have a very much higher prevalence of bicuspid valves. So watch this space in the US. In summary, for the patients with aortic regurgitation being treated with TAVR, there are patient challenges. They are younger patients. A lot of them have coexisting heart failure and pulmonary hypertension. There are procedural challenges. They have larger annular sizes, often secondary to a coexisting aortopathy. There may be embolization or migration from the lack of calcium, although this is improved with the addition of larger valve sizes, even with the commercially available valves. Residual regurgitation due to difficult placement. Again, the rates of those have come down as we see these newer devices with these fabric skirts to mitigate paravalvular leak. And we're seeing improved outcomes with these newer generation devices in addition to the greater size variety and the adaptive seals, the ability to be repositioned or recaptured, as well as mechanisms in the valve design to grasp the native leaflets or anchor in the native valve annulus. I still think further studies are needed with larger volumes and development of further suited devices for aortic regurgitation specifically. Thank you.
Great, thank you so much, Dr. Sharma. In the interest of time, let me go ahead and introduce our next speaker, Ms. Amy Simone. She's a physician assistant and a director at the Marcus Heart Valve Center. She'll be speaking to us regarding integrating APPs to optimize team-based care of the patient across the continuum of care. And Amy, I believe I may be sharing the slides for you at this time. Is that still true?
That is totally fine. Can you hear me okay?
Yes. So let me go ahead and share the screen here. Okay, hopefully you can see my screen.
All right, thank you. Well, good evening, everyone. I'd like to thank Dr. Khan, Dr. Gulati, and Viet Lee for the very kind invitation to participate in this fantastic event, especially amongst such an esteemed group of presenters. It's an honor to be here. So thank you. And as Viet said, I'll be discussing integrating APPs to optimize team-based care of the TAVR patient across the continuum of care. So I could talk about this for 10 hours. Let's try and consolidate this into about 10 minutes. So we're going to dive right in. Next slide. So these are my disclosures. I'm on Speakers Bureau for Boston Scientific and Edwards Life Sciences, but probably my largest disclosure as it pertains to this presentation is that I am an APP. I'm a physician assistant in my 15th year of practice, the last decade of which I've spent in the structural heart arena. I'm extremely passionate about structural heart disease as well as cardiovascular team members and the integral and invaluable role they play in the American healthcare system, and also the contributions to team-based care and collaborative practice. So I come at this with a certain amount of bias, but I think it probably is beneficial in this conversation. Next slide, please. So objectives I plan to illustrate over the next few moments or a few minutes. So APPs do provide cost-efficient, high-quality, patient-centric care, which allows programs to grow and evolve. Dedicated structural heart APPs utilized to their highest scope can improve efficiency, quality, and productivity across the TAVR care continuum. Specially trained APPs contribute to optimal patient care, experience, and outcomes. And as physician extenders, APPs are the key to increasing programmatic volume by safely increasing throughput. So we're going to touch on each one of these points as we go on. Next, please. So just sort of an overarching thought here, where do you start? You know, how do you create the right culture for really cultivating this healthy team-based care environment? And really, these are just some of my initial thoughts, but this must be supportive, right, from the top down. And I think that's from administration to physician leadership to the key stakeholders in the team. And it's really just got to create this really nice culture, which is, of course, collaborative, respectful, trusting, empowering, and appreciative with seamless communication. That's absolutely key. Well-defined roles and expectations of the APP team is critical. And of course, giving work, which is requiring APPs to work at the top of their scope or top of their license, is also just absolutely essential. Next, please. All right, so when we think about the TAVR patient, this is of course a long journey that these patients embark on when they're, first sent for referral and then ultimately, end up with a valve. So I broke it into four really kind of what I call stops along the care continuum, if you will. So we have the TAVR workup, the TAVR procedure, the post-TAVR inpatient period, and then the TAVR follow-up, which is the outpatient period. So we'll go through each of these stops very briefly and discuss how APPs can participate in each stop along the way, how to integrate that care, what are the benefits to include APPs on the structural heart team, and then also how do the APPs contribute to programmatic development, optimization, and growth. So let's get into stop number one. This is the TAVR workup. This is the point from which a patient is referred to your program to clinical disposition or treatment plan. So APPs, when a referral comes in, they can conduct pre-consult chart reviews in which they take a really deep dive into the patient's medical record and ensure proper imaging is obtained, so on and so forth. This is really necessary to identify who the patient needs to see at their initial consultation. Is this a dual appointment, a combined valve clinic where the patient needs to see interventional cardiology as well as cardiothoracic surgery, and also to, of course, streamline testing. We've been doing TAVR here in this country for a while now. This is not a new concept, but of course, someone straightforward on paper appears to meet all the appropriate use criteria for aortic stenosis and is a clearly high-risk patient on paper. Well, can we, if the GFR is acceptable, can we go ahead and get their TAVR CT the day they're here for consult? That sort of thing, streamlining the testing. There is some opportunity for non-face-to-face billing in this pre-consult chart review period, and that of course does correlate to RVUs and productivity, incredibly important for your APP team. APPs can also construct this initial consult note and participate in consult clinic alongside the physician and colleagues. This note I consider to be almost the source of truth, if you will. It's a very comprehensive, very thorough past medical history, which of course correlates into an accurate STS score, which is just a jumping off point for risk sort of stratification, but incredibly important. And it tends to see that consult notes tends to be taken through the entire kind of TAVR journey for that patient. So it's an important note that applies to inpatient consults as well. APPs can quickly identify potential research candidates. If someone looks appropriate for a particular clinical research trial, can get in touch with the research coordinator team and put that into motion very quickly. After the patient has been seen by the physician and the ball is set in motion, the APPs can communicate with the valve coordinator. Is there some sort of special testing required? For example, a patient with severe AS claims that they're asymptomatic and perhaps there's a stress treadmill that needs to occur, something like this. APPs can then be that first line of interpreting the screening test results. For example, TAVR CTs, it's not uncommon to find something incidentally. Is this a spiculated pulmonary nodule? Does the patient need to go to pulmonary lung nodule clinic or something, or obtain some other sort of clearance prior to procedure? If there's something concerning on the coronary anatomy seen on the TAVR CT, kind of make that decision that the patient does need a coronary angiogram to complete the workup, that sort of thing. And then of course, APPs do participate in the ever so important weekly multidisciplinary heart team meeting. Here at my institution, the APPs are the ones who are actually real-time documenting the discussion that's going on in that multidisciplinary meeting with regards to the imagers and the surgeons and the interventionalists. They're real-time documenting. So at the end, there's this really nice comprehensive note about what the patient's plan is that's embedded in the medical record and transparent for all who can who do take a peek. So moving on to the next step. Next slide, please. So now we're in this stop, the TAVR procedure, right? From shared decision-making process to procedure itself. So once the heart team has made the recommendation about treatment plan, of course, there is this shared decision-making that needs to occur between APPs or potentially physicians and the patients. It's a very critical piece of this story. I feel that APPs are instrumental in. They can convey complex treatment plans and discuss what that may entail. For example, electrocautery techniques and basilica to avoid coronary occlusion, that sort of thing. Alternative access, as you heard Dr. Grubb elegantly describing, cable access, transcarotid, whatever the case may be. Preoperative visits, including the usual education, then reviewing laboratory results, EKGs, that sort of thing, as well as obtaining that procedural consent. There's a lot of education that takes place in this visit as well. And I feel like that also lends to a very a very high touch sort of concierge feel, a patient experience, right? APPs are, of course, the ones who really compile that very thorough, very comprehensive H&P. Now, that clinical documentation needs to be consistent throughout the hospitalization, but in turn reflects the acuity of the patients. And it all comes down to the documentation, right? Because we all want appropriate credit for taking care of these sick patients, and DRG assignment and distribution is incredibly important. APPs documentation absolutely plays into this. And as I alluded to a moment ago, patient and family experience, setting the proper expectations around the procedure, length of stay, recovery, what to expect. It's just incredibly important to provide the patient and the family a realistic idea of what's going to happen, and the APPs are instrumental in that. Moving on, next slide, please. So the inpatient post-TAVR period. So this is the point from procedure to discharge in the hospital. APPs ensure optimal post-procedure care, whether the patients are fast-tracked, if you will, bypassing the ICU, going to recover on the cardiac step-down floor, or if they do end up in the ICU, critical care for whatever reason, APPs can ensure proper trajectory. And what I mean is that the patient's recovery is not veering off course, and of course, with an emphasis on patient safety at all times. APPs can emphasize this evidence-based practice as standards of care evolve, as they do very rapidly in the structural heart world, specifically in terms of minimalist procedure, minimalist recovery, all with patient safety at the forefront. APPs, a contact for clinical nursing questions and concerns, that face of the program, if you will, on the floor for nurses to reach out to, as physicians are typically scrubbed in procedures. APPs ensure timely and safe discharge for patients home, with, of course, all the usual considerations, including event monitors, antiplatelet agents, oral anticoagulants, AV nodal blocking agents, and also attention to whatever the incision site may be, providing robust instructions for how to take care of yourself at home, what to expect, medication reconciliation, that sort of thing. TVT registry requirements, of course, are mandatory, and APPs make certain that these things are collected before the patients are discharged. Participate in heart failure teaching, and then, of course, aid in communication with referring physicians, and a super important part of the heart team here, if you will. So, conveying anything incidentally that might have been seen on TAVR CT, discharge summary, these things, it's lucky if the patient is within, if the referring is within our electronic medical record, it's easy to route things to them. But if not, ensuring that phone calls and packets are made, that sort of thing. Thank you. Moving on, next slide. And finally, the outpatient TAVR follow-up from discharge to office visits. How can we integrate APPs? APPs, they can act as a resource for the patients when they go home for clinical questions, concerns about medications, incisions, what have you. Event monitor results typically come to the APPs first. In terms of new atrial fibrillation, perhaps we need to start an oral anticoagulant, or if there's a more concerning, more substantial conduction disturbance, that sort of thing, the appropriate swift measures can be taken. APPs can participate in independent TAVR follow-up clinic, 30 days in 1 year as mandated by the TVT registry. Of course, in the era of COVID, that has changed a little bit, in person versus telemedicine, hybrid approaches, that sort of thing. But there are very strict data points that should be collected to aid in your program, and more important as time goes on, in public reporting and so on. But APPs, of course, can monitor valve function. They're looking at PVLs, elevated gradients, anything concerning. And this is a really nice kind of aspect of the continuity of care throughout the care continuum. The APPs, they've met the patient at consult, they've cared for them in the hospital, they're seeing them in follow-up, and the patients are now coming back and with an improvement in their quality of life. That's just incredibly gratifying for the APPs, and that also translates, to the whole team. We are doing good work here and changing patients' lives. Again, TVT registry requirements, and APPs can communicate any changes that are made during these follow-up appointments, of course, to the referring provider. Next, please. So kind of an overall summary slide, the benefits of structural heart APPs, again, with my bias in mind. APPs can manage the inpatient service while physicians are in procedures. That's, of course, working everyone to the highest level, highest scope of their license. Document appropriately to reflect acuity, and then that translates to the DRG assignment and distribution for your program. hold independent follow-up clinics to allow physicians to see more consults and increase throughput. That's how you are able to safely grow your program with a high attention to clinical care and outcomes. Conduct institutional in-services to keep staff updated and engaged. This is critical, especially with large volume centers which are involved in a number of research trials, keeping the nursing staff, cath lab staff, OR staff, everyone up to date as far as what is this trial, what is this device, how do I care for these patients? That engagement is extremely important and critical to the success of your program, really. APPs can ensure evidence-based processes and standard of care are implemented, and of course act as patient advocates with an emphasis on shared decision-making at that point prior to procedure. And finally, APPs educate and navigate each patient along their journey, which in turn builds your brand, increases referrals, and differentiates your structural heart program. Next slide, please. So finally, in closing, as physician extenders, APPs integrated at each stop along the TAVR care continuum will improve efficiencies, processes, and productivity. APPs provide cost-efficient, high-quality, patient-centric care in an evolving structural heart program, and APPs are the key to increasing programmatic volumes and throughput with a focus on patient safety and outcomes. And dedicated structural heart APPs utilized to the highest scope can improve TAVR patient care across the continuum. And it all starts with creating the right culture that will cultivate that team-based collaborative care model. Next, please. I'd like to thank you all for your attention and for including me in this very special event. Please screenshot this email address. I would love to hear from you, questions, concerns, comments. I wish you the best and thank you so much.
Thank you, Amy. Next up is Dr. Mac Ansari. He is the endowed professor and director of cath lab at Texas Tech University. Mac?
Yes, can you guys hear me?
Yeah.
Okay, so let me share my screen. Share. All right. Okay, can you guys see my screen now?
Yes, we can.
All right, so the topic assigned to me is TAVR and antiplatelets. And why this is very interesting because when we started the program here in Western Texas, this was a question a lot of primaries, a lot of physicians, a lot of people who take care of their patients for a prolonged period of time had after TAVR, what to continue and how. So these are my relevant disclosures to the topic. So in 2017, the AHA and ACC, they came up with guidelines for aspirin and Plavix, clopidogrel, for 3 to 6 months after TAVR, for patients who do not have any indication for long-term, and use of oral anticoagulation. The first 6 months for the SAPIEN and for the first 3 months for the Evolute. And the reason was that they mentioned the endothelialization of the stent frame takes approximately 3 months that we saw in pathological slides. So going from there were multiple studies and meta-analysis done. And just to simplify everything, coming down to this one trial that was very recently published, and I will go into detail of this because this was very unique, that it summarizes everything and was very well done. And it was the European Union and the Netherlands that provided grant for this study. So aspirin with or without clopidogrel after TAVR. And this trial was designed, the popular trial was designed in the way that aspirin alone versus aspirin plus clopidogrel in patients undergoing TAVI who did not have an established indication for long-term oral anticoagulation. It was randomized, open label. All patients who were scheduled to undergo TAVR did not have an indication for long-term oral anticoagulation across 17 trials, 17 studies in Europe, and quite a nicely designed 343 with aspirin monotherapy, 347 with aspirin plus Plavix for 3 months. And most of them completed study other than very few that were excluded due to the exclusion criteria. The baseline characteristics were quite similar across both the groups. And if you see that the dosage were slightly different, but not really. Like if you look at the aspirin, 80 to 100 milligrams, Plavix was 75, 300 loaded if they've not loaded before. And during the TAVR procedure, the unfractionated happened with the ACT goal of 250, and post-TAVR, the onset AF needing either DOAC or warfarin. In 44% patients with aspirin alone group and 32 with aspirin in the Plavix group. And what we saw in this group is actually there were two outcomes. The primary was they talk about the bleeding, which was all bleeding that was procedure related or non-procedure related bleeding over a period of 12 months. And when I talk about the secondary outcome, it was the secondary composite one, which was bleeding or thromboembolic events, or secondary outcome, which was composite two, which was death or from ischemic stroke or MI. And what we saw, their definition of bleeding was very unique in the sense that they talked about intracranial bleeding within 48 hours after a surgical procedure. That was what they described major bleeding, or reoperation after closure of sternotomy for the purpose of control bleeding, transfusion for at least 5 units PRBCs within a 48-hour period, or chest tube out with 2 liters. And I don't know how they came up with this, but they actually, this is their defined parameters that they defined for the trial. There are other trials that have something similar related, but not precisely this one. And although most of the bleeding was TAVR excess site, and they described others as non-procedure related. And coming back to this, if you look at, this is the primary outcome, and this really summarizes everything. If you look at the aspirin alone compared to the aspirin and Plavix one, if you look at all bleeding, it's statistically significant, pointing towards aspirin alone when it comes towards reduced amount. And non-procedure related bleeding also, that was statistically significant. Coming back to the secondary outcomes, if you look over here, we talk about 2 analyses that they did. For the first composite secondary outcome, there was a non-inferiority analysis and the superiority analysis. Both were statistically significant. When you come to the second composite secondary outcome, which was MI and stuff, only the non-inferiority analysis was statistically significant, but the superior analysis were not found. But anyway, the majority of them point towards single antiplatelet therapy versus dual. Coming back to the other form, this is just really interesting. If you look at aspirin alone versus aspirin and Plavix, comparing ischemic stroke and myocardial infarction was similar across both the groups. So with the 2 primary outcomes, all bleeding and non-procedure related bleeding at 1 year, were lower among patients who received aspirin alone than among those who received aspirin plus clopidogrel for 3 months. This is mainly driven by differences in the incidence of major bleeding, what they defined in their definition. And there were similar results in another trial, the ART trial, which shows lower incidence of bleeding associated with aspirin alone than with aspirin and clopidogrel at 3 months. And in this one, it was 3 to 6 months. So coming back to the secondary outcome 1, which was procedure, non-procedure related stroke versus an MI, and secondary outcome 2, which was aspirin alone, was non-inferior to the combined therapy, but not superior. So slight difference over there. The incidence of thromboembolic events of stroke and MI in the current trial was similar, and we talk about that. It was at both the groups at 12 months. And these results were similar in the data across other trials as well, that the similar trial that was done at SAT-TAVI in 2014 and the ART trial in 2017. So far, if you look at this graph, it clearly shows that aspirin, the single antiplatelet therapy, was preferred as with lower bleeding risks as compared to the dual antiplatelet with aspirin and clopidogrel. And if you look at this, when we talk about the other indexes, also not much a big difference, but clearly pointing out towards single therapy as superior to other when you talk about the percentages. So among patients who did not have indications for long-term use of oral anticoagulation, who were undergoing TAVR, aspirin alone was associated with lower incidence of bleeding, safely say with this trial and the other trials if we combine all this, and the lower incidence of composite of bleeding and thromboembolic events. Aspirin alone was non-inferior. So what we also did, Sohail, is we composited Texas Tech University Health Sciences Center, looking at our area and our patients. We came across another meta-analysis and looking at our patients to combine the data and see, and we also got similar data that we have submitted into press as well. So it appears that the results are reproducible if you go to individual sites as well. Anyway, so first, this was an open label trial. Patient investigators were aware of the treatment assignments. Second, the trial, these what we talk about the limitations of them, particularly coming back that when we talk about these trials, particularly with the definition that they suggested, and I have not come across trial which individually has assigned CT scan to confirm the event of thromboembolic events in these patients. So these were the limitations of the study. So current recommendations, coming back to the other topic that we have to finish for patients post-TAVI. I'm sorry, I'm going a little fast just to make it in time because this is a very interesting topic with a lot of questions arising. So the second thing is for patients post-TAVI with the concurrent indication of your target is INR of 2.5 and no additional antithrombotic therapy. Example, if there's a mechanical mitral valve on warfarin with INR around 3 with low dose aspirin, no additional antithrombotic is indicated post-TAVI. Now, This is another trial. This is currently similar, but a different cohort. Anticoagulation with or without clopidogrel, published in New England Journal after TAVR. And the background was the rules of anticoagulation alone, with and without, with and with an antiplatelet agent, or just it alone. So cohort A we talked about, which was no indication of anticoagulation. This is the cohort B that established the indication in those patients that already have an established indication of anticoagulation. And the main exclusion criteria was drug-eluting stents in 3 months and bare metal stents in 1 month before TAVR. That was the main exclusion criteria. So these are the patients that did not undergo coronary stenting. All patients were on anticoagulation before randomizations, so DUAC or VK warfarin with Goel of INR2 to a 1-to-1 ratio. And clopidogrel versus no clopidogrel, but at 3 months. So this is the definition, the designation of the trial: 164 on one side and 162 on the other. And if you look at the ratio, 157 completed the 12-month follow-up and 156 on the other, and very similar, only 6 or 7 excluded due to those reasons. The composite, there were 2 secondary outcomes. Primary was, of course, related to bleeding, and the second was composite of death and cardiovascular causes, and composite of death and ischemic myocardial infarction on the second. So just quickly, this is the thing. If you look at all bleeding, statistically significant, again, if you talk about anticoagulation alone versus anticoagulation and clopidogrel, and non-procedure related bleeding is again the similar. And if you look at the secondary composite, non-inferiority analysis also pointed out towards the same direction, as well as the superiority. When you go towards the secondary composite, you see the difference that the superior analysis were not met, but the non-inferior analysis was met. So same changes over here. We talk about anticoagulation alone versus anticoagulation and Plavix. The preference was anticoagulation alone over those who qualify for anticoagulation. So there's no need to put extra stuff if you want to reduce bleeding in this page, in these patients. So the primary outcome, oral anticoagulation alone, was associated with lower incidence. So when we talk about double therapy or triple therapy, this trial and the meta-analysis related to it clearly pointed out. When you look at another trial that was published by George Dangus in January of 2020, patients with established indication or anticoagulation, they would talk about the DUACs, rivaroxaban 10q plus aspirin was higher risk of bleeding and death as compared to those with aspirin and Plavix alone. I won't go into this other trial, but I will just conclude in the thing of time when we talk about this would be the final take-home message. So when we talk about the DUAC therapy was associated with reduced long-term all-cause mortality compared with VK therapy in this particular trial, but this was only looked at patients. It was a very small amount of patients, and there was a lot of other questions coming out from this trial. So the rates of long-term bleeding and ischemic events were discharged were comparable between both warfarin and DUACs alone, if you see. So limitations again was there was non-randomized, and the need is for a randomized trial to do a direct comparison between the two. There are small done, but not sufficient enough. In future, what we are looking forward towards the Atlantis trial, which will talk about apexaban versus the current standard of care, which is either VK or antiplatelets as appropriate, and the InvestiStavi trial, which we were also part of and we concluded, in which we're talking about the Japanese drug indoxaban versus the current standard of care. And the again, final take-home message is when we talk about all our primaries in this entire region of Western Texas, we try to avoid triple therapy, so not to give bleeding complications to our patients. Thank you very much. If there's any questions, let us know. And our trial, which we have submitted for publication, thanks to our help with Nitish Mittal and my fellow Lat, will be published soon, which will be more details on the similar matter. Thank you very much.
Thank you, Mac. It was a great talk. Our last talk for this evening is TAVR and Beyond, a heart surgeon perspective. Our speaker is Dr. Mubashir Mumtaz. He's the Chief of Cardiovascular and Thoracic Surgery at UPMC Pinnacle.
So can you enable
Mumtaz, are you there?
screen sharing, please?
Viet, can you do that, please? Can you stop sharing, Dr. Ansari?
All right. I thought I did.
We can still see you there. So while he's doing that, we might go a little over time. We'll stay for another maybe 10 minutes for Q&As. Dr.
My
Mumtaz, can you share
apologies,
your
I'm not able to get Dr. Mubashir. You might
I've
have
stopped
to.
sharing mine.
Oh, okay. And then for some reason, I can't give him co-hosting ability there. So
Can you try now? I just made you co-host.
Okay, perfect. There we go. All right. So Dr. Mumtaz, you should be able to now share your screen.
Perfect. Thank you very much. Great forum, great session, Sohail. Thank you for inviting me to speak. It was great to see some surgical slides from Samir and Dr. Grubb, and hopefully I'll be able to show you a little more. Can you hear me and can you see my slides?
Yes.
Yes, we can.
Great. Okay. My disclosures. So basically, I'll talk about our TAVR and SAVR journey. At UPMC Pinnacle, we started our first TAVR in 2010. So it's a decade-long journey. And what I learned as a surgeon, and talk about some future therapies that will be part of going forward. So it was a whirlwind, being a surgeon and being part of the heart team. Despite all the bruises and stuff, I think that's the best part and the byproduct of this TAVR era that happened to our specialty. At UPMC Pinnacle, we call this the roller coaster of TAVR, because as you can see, our surgical valve volume almost doubled after we started enrolling in our pivotal core valve trial. And subsequently, a few years later, once we got involved into the low risk trial and subsequent approval of the low risk indication, we saw decrease in the number of aortic valve cases as the TAVR skyrocketed. The best thing I think that happened in our specialty was our patients. This was a 105-year-old lady, which Dr. Hemelgard and myself treated, and she continued to do well. Interestingly, I had seen her like 4 years before and offered surgery on her, but she refused at that time, did not want to live any longer, but then decided to get TAVR once that got available. Where did surgeons really play a role in the TAVR area? I would say in all aspects of TAVR, especially in increasingly complex cases, communication between anesthesia in the beginning, as being in the hybrid room or an OR setting was something new for my cardiology colleagues, and truly backing them in very difficult, complex situations. We helped in enrolling patients, and obviously when time came to make the things percutaneous or minimalizing the procedure or optimizing the procedure, I think that partnership really helped and flourished. In Pennsylvania, according to the Pennsylvania Health Cost Containment Council, you can see the trends as well. But interestingly, on the right side, that you see that the mortality, both on the surgical and the TAVR side, continue to decrease. I think on the surgical side, because there was a risk swap, we handed off all the extreme risk and high risk patients to TAVR. And on the TAVR side, due to improved technical considerations and all of us getting comfortable with each other and the procedure itself. As surgeons, we didn't lay idle either during this time frame. And these last 10 years, we developed our less invasive valve program. We called it I-SAVR initially, intercostal surgical aortic valve replacement. When I finished training for Cleveland Clinic, we were mostly doing partial sternotomies for less invasive surgery. Subsequently, surgeons started doing right anterior thoracotomy, as you can see here. And we said we're going to take this incision even more lateral and do the procedure through a much smaller incision rather than a sternotomy. And today, all complex valve procedures, double valve, triple valve, mitrals, aortic, are done through this small incision. An example of the mitral procedure, we continue to improve our repair techniques. Good example of degenerative MR with P2 prolapse, checking it in the OR, resecting the valve, putting a ring in, and these are the results that we started to produce day in and day out as we improved not only our TAVR techniques, but also our surgical techniques. And this was the end result of that. So we survived by staying relevant not only in the structural heart arena, but also by making surgical procedures less invasive. We saw increase in our complex valve volume and also in our mitral valve volume. There was a dip in our coronary volume initially in 2013-14, but that also rebounded, and that's made us one of the very busy programs in central Pennsylvania. Don't forget some of the victims of the TAVR story. Everybody remembers Direct Flow Medical. I know seeing Samir in some of those meetings when we discussed this platform. So currently TAVR is approved for basically every indication under the sun with multiple different devices. But TAVR obviously will continue its meteoric rise with all the trials that are ongoing. Some of them were mentioned during this forum, like the TAVR Unload, Watch TAVR that Samir is leading, Jenna valve. And I'm very interested and excited about seeing that there will be a trial in small annuli between SAPIEN and Evolute, because this is where as a surgeon, we used to get into arguments whether a porcine surgical valve is better or is a bovine valve better. And we're going to see the same debate and the same therapies going forward head to head on the transcatheter side. We will continue to see improved technical considerations. We did 2 Basilica today, actually yesterday with Hamel, which went very well. So we will continue to see increased, more comfortable with new technical considerations. Whether we will see improved stroke rate is yet to be seen. We use Sentinel routinely on our patients because I think there's a good number of patients in which we need Sentinel because they have a heavy burden of calcification, or for example in Basilica procedures. So even though the jury is out there, I think this technology will continue to rise as well. Durability is obviously very important, and that's where the true success, long-term success of TAVR is hinging on. And hopefully we will not see these early structural valve degeneration in the surgical valves. And with the advent of new tissue therapies like the Resilia tissue in the Inspira surgical valve, we will see improvement in tissue treatment for TAVR valves as well. Pinnacle will be part of the Picardia as well. So maybe we'll improve the native valve durability by scoring the calcium on that valve going forward. Some exciting areas are polymeric valves, whether they're silicone-based or polyurethane-based. This is an example on the left side of a polyurethane-based valve out of a company in South Africa that I visited 2 years ago. Very interesting technology. We all know about the tri-heart valve. This was a surgical valve implanted in a handful of patients in the US. And we'll see how these technology take us further. Obviously, don't forget, don't underestimate the medical management. With time, I think there's a lot of interest generated in this area as well, and would not be surprised if we see some stuff coming down the pike regarding this as well. So AVR surgical AVR will stay relevant in small aortic sinuses, lower coronaries where you require root enlargement and concomitant procedures. However, the meteoric rise of TAVR will continue. When it comes to durability, as surgeons, we still don't have any good solution for younger patients. Mechanical valve is a good option, but again, anticoagulation is an issue. I have a patient in the hospital today who had a mechanical valve put in 10 years ago, and now there's one of the leaflets is frozen, and she will require a redo operation tomorrow. So we run into these issues, and that's what interested us in getting involved with Ozaki procedure, which is basically reconstruction of aortic valve with native pericardium. The hypothesis is that having your own tissue will generate less amount of autoimmune phenomena, so maybe the durability of these valves will be higher. Dr. Ozaki has presented data on 1,100 patients over 12 years and only 32 of those patients required a reoperation. So we cut these 3 leaflets out of stencils, which we have available to us. And then we sew the valve in, and it looks like a pinwheel valve after we're done. 3 months post-procedure, it looks very similar to your native valve. These are 2 of my younger patients that I've done this procedure on. Both of them are 4 years out. We've done a total of 37 procedures. 2 of them required reoperation. What we have learned from those 2 reoperations was that the aortic root anatomy is very important. And if the root is significantly enlarged, it's probably not a good idea to do this reconstruction. Beyond this, obviously transcatheter mitral therapies will continue to grow. A lot of interest. The next decade will belong to them. At UPMC Pinnacle, we are involved in a bunch of the trials, whether it's Pascal or the CLIP on the tricuspid side, Cardioband, mitral repair and degenerative valves with Newport and Harpoon, transcatheter mitral repair technology, AccuCinch, which is ventricular plication below the mitral valve. We've done 5 cases, and we recently did anterior apical aneurysm plication in a patient using BioVentrix technology, which also is great and worked out very well for us. So this is a summary slide. Basically, our journey on the TAVR side will continue, and surgery will stay with more complex cases and slower innovation. And the next decade will probably belong to TMTT and SpaceX. Thank you.
Thank you, Dr. Mumtaz. I know we are a little over time, so I'm just gonna stay for 10 more minutes if all our faculty come online, or they're already online. But Dr. Goswami, are you there? We can't hear you.
Let me unmute myself.
All right. So do we have any burning questions for the faculty, or the faculty have questions for each other? This is the forum that we can ask some questions.
Yeah, I'll start with a couple of questions, and in the interest of time, we'll try to make it short. But first of all, congratulations. You had a multidisciplinary all-star cast, and they did not disappoint with their delivery. And you also had a very robust number of registrations. So congrats to that during this COVID pandemic. But what interested me was the data Dr. Kapadia shared from the Cleveland Clinic about his stroke rate, ranging from 0.2 to 0.3% in TAVR, very low stroke rates. And so my question was, were these all sentinel cases? And if so, how do you mitigate the cost of the sentinel device and its contribution to the contribution margin for these procedures? Because this is something a lot of high volume hospitals look at.
No, you are absolutely right. So they are all sentinel cases. So we are using sentinel in 95% patients last year. So it is a cost to us. What we have justified is that the cost, and we are also trying to do the similar analysis for Medicare, but the cost of stroke is not inconsequential. Of course, the other major part for us that we say is that if our quality is excellent, we attract the best patients from all over the world. So in both ways, we justify the cost, but otherwise, you are absolutely right that if you just do proper accounting, this is a cost that is additional in terms of the bottom line. But luckily, we are a physician-driven organization. I'm also in charge of all these things. So what we can justify is that we are doing it for the right reason, because we don't have any other skin in the game to say that why we are using the device. But if our outcomes are excellent, if we are not doing harm, and if we have been able to reduce our stroke rate, it just is important for us to continue to use it. And this is how we have been able to use it.
Sure. No, I think that's a very good argument. And I think the trial you mentioned, Protect TAVR, is going to answer a very important clinical question, not only with outcomes, but also potentially economics.
Agreed. Agreed. That is the
so
purpose.
we should.
That is the purpose. So we will see, hopefully, and we may have a CPT code. There is some effort going on in terms of reimbursement. So we will see how these things work out.
Yeah, which would obviously help. Another question I had was for Sachin Goel, who I'm glad to see has made a smart decision to relocate down south from Springfield, Illinois. But in looking at some of these patients, particularly with regards to the early TAVR trial, and now we're looking at Medtronic is potentially looking at some of these moderate AS patients. You mentioned the role of BNP in these patients and the predictive value of BNP in these patients. Are you aware of any outcomes data or secondary endpoints in these trials that they're looking at BNP and outcomes?
So you mean in the TAVR unload and the early TAVR? I'm not
Correct.
sure BNP is specifically being looked at. I would have to be honest with you, dig deeper into the trial protocols, but there is plenty of data from Marianne Clavel from Mayo Clinic and from Montreal, looking at the utility of BNP, and in multiple studies, not just one study. BNP has been found to be a very important prognostic marker in both symptomatic and asymptomatic patients with aortic stenosis that are being followed, and also those that are undergone intervention on their aortic valve. So I think BNP is a marker of subclinical heart failure, and I think we'll see more data, especially in this patient population.
Right. No, I think it's a very good data that you showed, and I think it may change the way we kind of approach some of these patients. I think personally, it was eye-opening to me, and probably be something we start to incorporate routinely in looking at some of these sicker patients. Okay, I'll ask one more question about bicuspid aortic valves in patients with aortopathies as well. And how does having a simultaneous patient with severe bicuspid aortic stenosis and aortopathy or a dilated aorta impact your valve decision? We've had several patients go subsequently for reoperation, and our surgeons kind of complain about dissecting out the self-expanding valves in comparison to a lower profile, lower footprint balloon expandable valve.
Anyone take the question? Dr. Rahul Sharma, are you still there?
He had to help a fellow out in the lab. So
okay.
So I would say that you are right that this is a serious problem, because, and as you know, that there are two recent papers coming out to say how you operate after TAVR valve, and Cleveland Clinic also has their own experience ready to be published. It is a tough problem, because if you have a long self-expanding valve, to remove the valve, remove the root, and root replacement increases the amount of surgery, and this is a challenge. So in the future, at least we have to. That's why I'm saying the lifetime management of aortic stenosis is a very important concept and should be very carefully monitored, to say that how we are going to do SAVR now, TAVR later, or TAVR now and SAVR later. This is a tough question, and that's why I think the heart team approach, where surgeons are involved in the beginning, is crucial, because I think without a good surgical opinion, it is not a good idea to give opinion to a young patient, especially with bicuspid aortic valve and aortopathy, that what are the future options, and very important question.
All right, I have a question as well. Dr. Atianzar, Dr. Grubb, if you can answer, is cusp overlap your standard protocol implantation?
Well, I'm a bit biased as the national PI for Optimize Pro. I'm a proponent of it, and we adopted it in January of 2019 from my good friend Hamel Gata. He and I actually trained at Columbia together, and so I have a feeling that those numbers that were reported for pacemaker rates in the 17%, we are not going to see anymore. We're going to see single digits. Whether or not we can drive it down as low as what some teams are reporting. You know, Hamel's team is able to achieve pacemaker rates in the 3 or sub 3 range with the core valve. So yeah, cusp overlap is how we do the self-expanding valves at Emory. And we've had excellent results from that.
I think as Kendra mentioned, Hamel has taught this technology everywhere, and I think it's a very reproducible technology. I think it's important to understand that the goal here is to implant the valve in a shallow position. That's the name of the game in terms of reducing pacemaker rates. And I think it's important for operators to understand the differences between cusp overlap and the so-called LAO technique. That's the technique that I use, and we implant the valve. Our valve is extremely shallow and actually negative in LAO, which we know it's really not negative if you go RAO, right? I think this understanding, the ability of seeing this for operators in cusp overlap and in RAO projection is something that I think increases the reproducibility of this, and that's why it's been so successful. I know, just like myself and other operators, I think we can all do cases in different techniques, but the ultimate goal is to shallow implantation and the understanding of the differences of these two techniques to be able to achieve single-digit pacemaker rates as we do have here in Cleveland as well.
I have one last question for Dr. Kapadia, Dr. Mumtaz, is in countries like India or China, and then even about 8 to 10 million of people in the US, they don't have insurance. How can we make TAVR technology more affordable? And Dr. Mumtaz mentioned something about polymer valves. Is that something that is going to be the future?
Yeah, I mean, so Samir can chime in, but I think the third world TAVR will come from the third world countries. So I think I don't really want to say third world countries, but the countries in that part of the world like China and South Africa who deal with this indigent population, they're working on a lot of these therapies, even in India, for that matter. So this polymer technology is interesting, and I think it will continue to get better. Interestingly, this valve was manufactured in their lab for less than $100, including the stent and the leaflets on it. So I think to procure a tissue, whether it's porcine or cow tissue, is pretty expensive and difficult to do. And we've seen time and again. I mean, it's embarrassing that surgeons had 40 years to show what the durability of surgical valves was, but we never did. And now we're finding out that surgical valves were not that great, as we do TAVR in these valves all the time. So I think that will happen. We have to make it cheaper because majority of the people in this world are missing out on this technology when we are doing so well. And you feel that deeply when you visit some of these countries and you see these patients. One other thing is in the developing world, the patients are also much younger. So these therapies might not work for that population at all. I mean, we still don't know the durability of TAVR. Hopefully the low risk data will show us. But these valves may not show. If you use a tissue valve in that population, because majority of the patients are in their 50s, patients come back in 5 to 10 years, so on the average 8 years with restenosis. So in that population, the polymeric valves might be more important, and that's when this might start rolling out in general population in these countries.
No, I agree completely. I think that the cost of anything in United States or the world is a tough question. It stands, as you know, and everything. So as the new technologies come, people do new technologies for, eventually for business. So even though you may think that the new technologies will decrease the cost of things, typically they do not decrease the cost because people want to give the, make money. So the idea is that it has to come from indigenous country, because if that is how it is going to be. So that's why, for example, my valve and other valves and venous valve and other valves in different countries have, have gotten some leverage. The newer technologies, I think it will take some time before they get less expensive, as we all know, but we hope that some competition can bring it down. But this is a very good economical question, because if you want to have growth in the area, which we all want, then many times we have to pay for it. So this is a little bit of a plus and a minus.
I think we'll just take one more questions, and if there are no questions, we can.
Yeah, I have a question for Samir. I was impressed with the slide he showed for the groin access. But at the same time, I saw that Samir, you ended up putting a temp pacing wire. So why not use the LV wire? It seems to work for most of the patients. In bicuspids and heavily hypertrophic, it doesn't work as well. But what's your thought process on that?
No, I agree with you. I know. See, again, the cost comes into play. We have been using the Amplatz extra stiff wire instead of using the Confida or other preformed wires which conduct better. So the Amplatz extra stiff wire does conduct, but it is not that reliable.
Gotcha.
This is the reason why we are using this. For us, it is less cost. We are using 1 per close instead of 2 per closes. So there we cut the cost. Right. Of course, we use Sentinel, so we increase the cost. So all of these things are plus and minus, but ultimately the goal is to have the good outcomes. But the single groin, I must tell you, is a lifesaver for both, for me, for the fellows, for the patient, because if there is some slight narrowing in the groin, you don't do anything, just put a balloon through the inferior sheath and you're done in 5 minutes. So it is, or if it bleeds, you just inflate the balloon for a few minutes and it stops. So there is this is much better. And we put a straight flush catheter. So instead of using a pigtail, just use a straight flush with multiple holes. So you can pull back and push in without a problem. Otherwise, sometimes the pigtail may be harder to move in the same groin if the groin is tight. But the straight flush, it just stays there. You don't remove it. You leave it there, do your case, and then take it out. So there is, this has simplified at least our job. And all my colleagues, of course, we train them, but still, they all love it. So
no, I think that's great. I mean, I'd definitely be talking to Hamel about it. We should look into it. Yeah.
If you try it for a few days, you will, many times they want to put a sheath underneath, even if they don't need it, because they feel safe about it. That now, we can control the bleeding in the groin much easier. So this is I think the huge advantage.
Great.
All right. Any more questions? Well, thank you all. This was a great evening, and thanks for your patience, all the faculty who this your precious time out of their busy schedule, and we will keep doing this. Please stay tuned. And again, we will upload this on our YouTube channel and on our VuMedi channel as well. Thank you all.
Thank you. Take care, guys.
Bye-bye.